We'll start with this quote from the World Federation of Mental Health. It's speaking to the high rates of comorbid depression with chronic physical health conditions. So it's also the case that depression is second to heart disease in the global burden of disease. That means depression is not only common in those with chronic disease, but it's affecting the general public as a whole. And if we place that into the context of a pandemic, this work becomes even more relevant. So next slide, please. But in regards to chronic disease, if you look here at this graph, you can see that there is a higher prevalence of depression among a variety of physical health conditions. And the association between depression and chronic disease could be due to depression bringing about chronic disease, it could be chronic disease exacerbating symptoms of depression. So there's an implication that an integrated approach could be impactful if we're addressing both of these things together. And the same can also be said, next slide please, about other behavioral health disorders. So as we see here, the blue bar represents those who have been diagnosed with a severe mental illness, and the yellow is for those who have not been diagnosed with severe mental illness. And we can see from this graph that people diagnosed with severe mental illness have higher rates of chronic disease than those without. So this is just the other side of the same coin. It further shows the dynamic relationship between behavioral health and physical health conditions. It implies that one can influence the other. And another thing to consider is that mental health medication may affect or exacerbate physical health conditions. So again, knowing that there's a relationship between the two stresses the need to address both aspects. And then now we're going to look into a specific case here regarding suicide. We've discussed the comorbidities, and this is why we're focusing on primary care setting. So the dark blue bar represents primary care visits, and the light blue represents mental health provider visits. And the American Foundation for Suicide Prevention.
Sorry, Mariah. Sorry, Mariah. It's the other way around. The light blue represents.
The light blue. Oh, sorry about that. I literally just got them flipped. Sorry about that. So yes, like she said, the light blue is primary care visits, and the dark blue is mental health provider visits. I apologize. So they found that 38% of patients that attempted suicide made some type of healthcare visit within a week before. And the visit came within a month before the suicide attempt in 64% of patients, and then 95% within a year. And strangely enough, the percentage of visits with mental health or substance use providers was about 25% within a week, 44% within a month, and 73% within a year before the attempt. So you can see that there are much lower rates for mental health visits than primary care. And on the next slide, we have data for completed suicides. And the difference between mental health and primary care visits is even greater here. And I just want us to pause for a moment and think about that. Since primary care, as we can see, is the go-to for many people, how many lives could we potentially save by incorporating behavioral health services into primary care? So these primary care visits have huge potential for preventing suicides, but it also doesn't end with just suicide. The American Psychological Association actually found that about 70% of primary care visits have a psychological component, and only 10% of those patients will follow up on a referral to a mental health provider that's not co-located. So integrating behavioral health and primary care can increase access to mental health services and address a lot of barriers that exist to care. So moving on from that, we're going to segue into a more high-level idea, and then I'm going to pair it with a couple of scenarios to help drive the point home. So this model here is called the biopsychosocial model of health and healthcare. It's a lot of big words, but it's really pretty simple, actually. It suggests that health and illness are multidimensional. That includes biological, psychological, and social factors that all overlap with each other. So this model calls us to view health and wellness from a holistic perspective compared to, say, the biomedical model, which is more commonly used in healthcare settings today. For example, the biopsychosocial model allows us to consider things like social determinants of health when providing patient care. Also, within this context, I like to say our brain is part of our body, and our bodies don't exist in a vacuum. So therefore, we can use this model to inform healthcare delivery and address the patient as a whole. So let me give you a couple scenarios to explain this. So a patient comes in complaining of chest pain. In one case, in the biomedical model, the focus is on the physical causes of disease. The physician will ask a few questions on recent diet, pain history, family history. However, the signs and symptoms are what is considered paramount. For a diagnosis, the clinician will order objective lab tests and monitor vital signs, temperature, pulse, blood pressure, etc. And then eventually the doctor will prescribe a medication for the patient that's based on biological and physical considerations. So we know this model, but let's compare it to the biopsychosocial model, in which same complaint, chest pain. In this case, the goal is to understand social, psychological, and physical processes that may cause the chief complaint of chest pain. The physical or behavioral health provider, either one or both, may ask for a history of recent life stressors, anxiety, and other behaviors. For a diagnosis, they're going to base it on a combination of psychological factors and the standard lab tests. And the clinician will form a diagnosis and treatment plan based on multimodal assessments. As you can see here, we have the lab test, but we're also adding in maybe a few other assessments that may address behavior. And so then eventually the physician discusses the available interventions with special attention to behaviors and to lifestyle changes. And the patient is also involved in creating this plan, and they maintain a supportive relationship throughout the treatment plan. So I want you to just take a second and think about what the main differences between these two models are. The first one that I notice is the biopsychosocial model is not just looking at physical signs and symptoms, not just lab tests, but using different multiple assessments and looking at a variety of factors outside of just the physical realm. And then also in regards to treatment plan, there's special attention to behaviors and lifestyle changes that we don't necessarily see in the biomedical model. So as we move on, a main idea to take from this model is that there's often and almost always a behavioral aspect to physical disease, meaning that most physical health conditions are affected by behaviors. And next slide, please. Oh, Kara, we have a question.
I just have a question and a comment, not more of a question, but a comment. This is a question. How many times do we know people, or are we that person that you go to the doctor and you feel like there's something wrong with you and they're like, nothing's wrong. We did all our lab tests. You're on your way, right? And they never really do anything else. And people might stay sick because lab tests don't say anything. Whereas maybe a behavioral intervention, a psychological intervention might address some of those things that we're experiencing in our bodies.
Definitely. And that statistic from earlier was that 70% of primary care visits have a psychological component. So that speaks to that very well. Lab tests aren't going to catch it all, for sure. So there's a behavioral aspect to most physical disease. That's the key point here. And we can move on to the next slide. So that being said, here's some examples of behavioral interventions that have been successfully used to prevent, treat, and manage physical health conditions. All these studies were done in the context of primary care, and it's definitely not an extensive list. I could have filled up this whole slide, but we didn't because that would have taken a long time. So just take a moment to notice the variety of conditions listed here, and you can see that behavioral interventions in integrated healthcare are versatile and broadly applicable across many different physical conditions. Let's see. And so now that we're believers, I'm going to convince you even more. We know that those are all great reasons, but money is definitely a motivator as well. So this actually comes from a report done for the APA in 2017 using healthcare cost and utilization data to project spending estimates for people that have chronic medical and comorbid behavioral conditions. So medical costs, just to put it into context, medical costs for patients with chronic medical and comorbid mental health conditions are 2 to 3 times higher. So the costs for these people are 2 to 3 times higher than those without comorbid mental health or chronic medical conditions. And so according to this report, there's a projected $37.6 billion that can be saved annually, and that's the minimum by integrating healthcare at a national level. So there's a lot of potential for cost savings here. And this is a pretty large figure, but it's just, just to show that the country as a whole could really benefit from this. So now that we've discussed some of the stronger arguments for integrating healthcare, I would like to test your knowledge. We're going to launch a Zoom poll in a second, and when the poll appears, please tell me which of the reasons listed is why we should do integrated healthcare, and the question will appear on the poll. So let's see, I can do it, I suppose. Okay. Everybody see it? I'll give you a couple minutes. So far, everybody's a good listener. All right. Okay, so it's kind of slowed down, so I'll go ahead and show the results. So everyone got it right. The answer is all of the above. There are many reasons why this is a good idea. And really not one of them trumps the other. So good job. All right. And so now I'll pass it. We're going to actually pause and take questions, comments, concerns. You can unmute yourself or type in the chat box. Anything? Okay. Yeah, so at any point, y'all can raise your hand or just type in the chat box and we'll be happy to answer any questions y'all have. I'll go ahead and pass it on to, is it back to Sujina? Yes.
Thanks, Mariah. So we're going to talk about what is integrated behavioral health. And before we do that, it's important to talk about the key models, no matter key elements, no matter the model. When we talk about integrated behavioral health, there are very specific models which we will discuss later, but before we do that, we need to understand that no matter the model or the type of integrated care that you want to provide, you have to understand the key elements of integrated healthcare, because without these key elements, you would really be missing a step in access and quality in integrated care. So first off, it should be person-centered. It should be a person-centered team care that is collaborative in nature. So it should not just be about co-location where you have your behavioral health provider in your office. It should be more than that, where your team members are learning to work together in different ways, making decisions collectively while keeping all mental, behavioral, and physical health in mind. It should be population-based care where the care has access to shared records. They look at quality outcomes and measurements and adjust those measurements so that no one falls through the crack. Keeping the population-based also in mind, there should also be measurement-based treatment to target, and those treatments should be actively changed until the clinical goals are achieved. There should be evidence-based care, which includes brief intervention, which we will touch base on later, but there should be consistent evidence-based care that are based off of, let's say, for example, brief intervention. And lastly, not only should the team work together with the patients, but your patients should also experience that one-stop shop where all of their needs are met in one place. So this is the framework of integration. We're now going to talk about the levels of integration, and they are categorized as coordination, co-location, and integration. We're going to talk about each of these categories individually. But before we do that, I also wanted to share with you guys the level of integration. So there's level 1 and 2, which is going to be, which falls under coordination. And this, by the way, is from, we took this out of Center for Integrated Health Solutions. They have this scale provided for us, so we're just sharing that with you. We're going to go over these and look at them in several different ways, but as you can see, level 1 and 2 are minimal and maybe a basic collaboration. 3 and 4 is a bit more collaboration and some integration. And level 5 and 6 is a close collaboration and fuller transformation. But let's go ahead and talk about each one of these individually. So when we are talking about coordination, here we discuss patients and exchange information. Providers may collaborate at a distance if it happens at all. As I mentioned earlier, it's the traditional way we, as patients, access care. You go to one place for your physical health provider and may go to a completely different separate location to see your behavioral health provider. To visualize what I just discussed, here is an image. As you can see, here's a patient that might be going through a physical, going to a physical health provider or a behavioral health provider. As you can see, the primary care provider is working with this patient on uncontrolled diabetes, insomnia, stomach pains, and at risk for high blood pressure. The same patient will have to drive across town, possibly to a different county, different town, to see a behavioral health provider because they may have some behavioral health concerns such as depression, anxiety, agoraphobia, insomnia, all in one person. This is definitely a possibility, but this is the standard way we see care right now for the majority of the population. When we get to the co-location, this is where you start sharing some facility space and have behavioral health provider on staff. You may share some scheduling staff and scheduling software. It means as a patient, these are all at the same location, same office. When a patient walks in, he or she will check in at the same place. Today, their visit could be with the primary care provider. In 2 weeks, they might have a visit with a behavioral health provider, but both providers are aware that they are a patient on both ends, and they may even occasionally discuss the care of this patient. But again, they are separate. As you can see in this image, we have primary care provider doing uncontrolled diabetes, insomnia, stomach pain, at risk for high blood pressure, and then we have a behavioral health provider who is taking care of depression, anxiety, agoraphobia, and insomnia. And even shown in this image, they're standing separately in 2 corners, just to show you what co-location might look like. And then when we get to the integration level, we are talking about transforming your practice, and you are truly merging your teams together to one shared space, patients, and outcomes. when we start talking about integration, we are putting these two providers together. They are working together with the patient to improve their health and their health outcomes. As you can see, I've crossed a few things off the list on the board of what these two providers are working on, because it might be too much for a patient, or it'd be too overwhelming for a patient to work with 2 different providers in 2 different visits and 6 different diagnoses. So the patient may want to start somewhere small. But if we are all working together, we are understanding that the behavioral health provider can also help with uncontrolled diabetes. The physical health provider can help with uncontrolled diabetes, insomnia, and anxiety. But lastly, these two providers working together can help this patient take ownership and really equip them to improve their health. So we are working with the entire team and patients, and that's really a fuller transformation, a merging of the practices and improving care at a level 5 or 6. So here we are with our level 1 through 6. As you can see, in level 1 and 2, when we talk about proximity, they are separate facilities, separate system, communicate rarely as provider needs, or periodically as patient needs, and they may never meet or meet as a larger community. In level 2, 3 and 4, proximity wise, they are same facility but separate space. System wise, they could be separate or some shared. Communication, they communicate regularly by phone or email, or regularly in person as needed. And they meet occasionally to discuss cases or meet regularly on some patients. And then lastly, when we look at level 5 and 6, proximity wise, they have some shared space or they share all space. Their system is partially integrated or fully integrated in some form or fashion. They communicate frequently in person or consistently as individuals and team. They provide care as a team, staff patient caseload together, and have regular team meetings or have team meetings about system and patients. Now that we've discussed and thoroughly reviewed the levels of integration, I would like to play a quick game, and I want you all to try and identify your level of integration at your practices. So what I'm going to have you guys do now is to open up your chat box and put it in your chat. Where do you think you are when it comes to proximity between the level 1 through 6? I just want you to put a number between 1 through 6 to identify where do you think you are when it comes to the proximity. Wow, we have 6, 3, 4. Veronica, 6, that's amazing. Erica says 4. Level 3. Okay, thank you for participating. Let's move on to the system. So what level do you think you guys are on when it comes to the system? Because sometimes you can be on level 3 with your proximity, but your system and that is really your appointment scheduling, your EHR, your shared notes, and your records, you might be on a different level. So thinking all of that in mind, can you identify at what level do you think you are when it comes to the system? Level 6 on system, we're getting 3, 3s. So mostly separate. 4, some shared, okay. 5.
I would say when we are working with practices, this is probably something that's concretely easy to measure. When you get to a 5 or a 6, that means the behavioral health provider and the physician are documenting notes in the exact same chart on the exact same visit. because they're working together. So if you're at a level 5 or at a level 6, you're probably having one electronic health record, not two separate, and the behavioral health provider is documenting in the primary care chart.
Beautiful. Now let's move on to communications. How often or in which way are you communicating with the team? And I'm talking about behavioral health provider here. I'm sorry, behavioral health provider team and primary care team communicating together. At what level do you think you are when it comes to the communication? Shirley says 5. We're getting 5 and 6. Francis says 5. Threes. So we have 3s and 5. Okay. And lastly, what about the meets? At what level do you guys think you are when it comes to meeting? Surely, I love that. So most of you are at 5, which is regular team meetings. That's beautiful. We're getting some 2 as a larger community. Okay, great job, everyone. Thank you so much for participating. So you might be on something such as proximity or system-wise shared at a higher level, like at a 4 or 5, but in other areas, you might be lower, and sometimes you want to focus on one of those areas to improve, because then you will improve your entire integration process. It's also to know that it's not just one thing to look at. It's not just the physical health provider and the behavioral health provider and their interaction. It should be about the entire system, your entire way of operating and caring for the patient when you're looking at the level of integration. Before we move on, if anybody has any question, this would be the time to either unmute yourself or type in your question in your chat box. We're doing great, I think. Okay, then let's move on. So next, we're going to talk about lexicon. So when we talk about lexicon, we refer to it as a set of terms used in a particular profession, subject, or style. Commonly, we might refer to this as shared language and shared definition. So for example, an example of lexicon for soccer would be terms such as linesman, friendly match, yellow card, as such. So when they are used, those are the common terms used in soccer, and when they use it, we know what they're talking about. And similar applies to integrated behavioral health. When we talk about lexicon for integrated behavioral health and primary care integration, it includes terms such as integrated behavioral health, co-located care, patient-centered care, coordinated care, team meetings, team huddles, meets and greets, warm handoffs, scheduled visits, PCP or cold consults, and group visits. I've already covered most of the definitions that are highlighted here, but we're going to talk about some that we haven't discussed yet. But before we do that, As you know, we love playing game here and quizzing you guys. Before we move ahead with lexicon for behavioral health, I want to quiz you guys very quickly and test your knowledge on the shared language. Please go ahead and open up your chat box again. And can you please type your definition of team meeting versus team huddle? I want to see if you'd be able to identify the difference between the two. Okay, hit enter if you're ready. Shirley says team meeting more than 15 minutes in groups, not necessarily standing. Anybody else? Shaina says team meeting are more formal and may run longer. Team huddles are smaller, more focused check-ins on certain topics, quick touch base. Okay, I need one more. Meeting. Time, team huddle, it's timed. Renee, I didn't realize you were here. Hi. You say team meeting, many topics, team huddles, specific purpose. Irene says meeting is new news, huddle is brief, prompt. Erica says, I would say that huddles are shorter and meeting can be more of tracking, more input. Great job, everyone. You guys are very well informed, but before we talk about the differences between those two terminologies, let's actually start by talking about the benefits of having a shared language around what we are doing in behavioral health. So first off, the benefit for having shared language is for patients and families to know what to expect from integrated behavioral health, for them to know what the integrated care, whether the integrated care that them and their family received was up to a standard. For clinicians and medical groups, we want to be able to have a common language so we are able to share a consistent message when we talk about integration. Most importantly, we want to be counted as genuine behavioral health integrated in primary care. And third, have a shared understanding of the core functions and what is it up to us to locally adapt. For policymakers, this could be in those situations where you're having a conversation either at a state or even at a local level with your payers, and you want to advocate for integrated behavioral health to be a paid service if in some scenarios it isn't. Again, very important for us to have shared language around what do we mean when we say that. And then for health plan, to have a common understanding of what specifically do I require clinic systems to provide to health plan members. And they also need to know what will they specifically look at to see if they're providing the services and how will they understand the function well enough to be able to price for them. And then when we talk about lexicon for integrated behavioral health, which is also called primary care behavioral health, it is a combination of medical and behavioral health services in a collaborative way to address problems that are identified in primary care visits. Here, primary care providers and behavioral health specialists work together with patients and families to address mental health issues, substance abuse, and behaviors that affect physical health. When we talk about co-located care, I've already discussed this with you guys, but just to recap again, this means the behavioral health provider and primary care provider are working in the same practice location to deliver the care. when we talk about patient-centered care, we are talking about patients' experience of transparency, individualization, recognition, respect, dignity, and having a choice in all aspects of their care. And when we talk about coordination, we are talking about coordinating and organizing patient care activities and information that are exchanged between the patient and a broader care team. Next, Mariah is going to talk about the team meeting and team huddles and really discuss the differences between the two.
Thanks, Eugenia. So we're touching a little extra on this just because sometimes it can be confusing, we can mix them up, and we want to be clear about when they're happening, how long they are, and so on. So with team meetings, it's going to be the entire team, including behavioral health, primary care team, but also front desk staff, medical assistants, case managers, everyone's involved. They're going to be more organized and structured. You might meet in like a conference room. It'll be a more formal meeting. It'll be detail oriented. So focusing on goals, tracking, like someone said earlier, and just, working together to meet those goals in more of a long-term view. And then also they're going to be less frequent. So by that, it could be, and we can go ahead and click forward. They can be weekly, they could be bi-weekly. Sujina, if you want to continue on. Let me click. Okay, cool. So yeah, someone said greater than 15 minutes. So 30 minutes to an hour even. And again, this is everyone that's involved in you discussing more high level things, and also discussing things about shared patients and goals for them as well. And that's in contrast to team huddles, which are, again, everyone is attending. It's not just behavioral health provider and primary care provider alone talking about patients. This is front desk staff, medical assistants. It's important that everyone's there because you're discussing tasks and action items for the day, for that specific day. And so it's going to be a quick meeting, maybe in the morning before the rounds, 15 to 20 minutes tops. And you're standing. It's not like you're sitting down with structured meeting items. It's very just on the go. What are we doing today? Who are we seeing today? And again, it's going to be more often. So this is something that should happen once a day, maybe even twice a day if needed, but it should be a routine thing that happens on a regular work day. And let's see. So keep in mind these differences that we mentioned, and we're going to give you a scenario, and we want us to tell us which one we're describing here. And it'll be another Zoom poll. So keep an eye on your screen for that Zoom poll. Here's the scenario. So primary care team meets daily at the nursing station at 7:30 a.m. for 15 to 20 minutes to briefly discuss patient visits for the day. Physician assistant requests the behavioral health consultant to assist with several scheduled patients. The BHC, PA, RN, and MAs, and front office staff all share other important plans or interventions for the day. So which one would you call this? And let's see, I can. Oops. I did that. Oops. Okay, everyone see the poll? Oh, I see. Here we go. There it is. Sorry about that. Have the other question. So is it a team meeting or a team huddle? Man, y'all are good. It's funny because I feel like in a past training of this, not everyone was getting it right, but everyone's getting it right this time. So it's a sign of improvement. It's great. Okay, so we've come to a standstill, so I'll go ahead and share the results. That is a team huddle. And we know this because it happens daily. It's at the nurse's station. It's early in the morning before the rounds. It's short and brief, and it's discussing patients and action items for that day. So those are the key differences there. And so now, do we have any questions so far? Take a pause. It's pretty straightforward, and y'all already knew it anyway, so. All right, so we'll go ahead and move on. Kara's gonna get into the nitty-gritty about the 2 models of integrated care, or it'll actually be an introduction because we do have trainings on these models. So she'll give y'all a brief intro.
Hey everyone, why don't we take a minute to, if you feel like standing up for a second or stretch your arms, we've been here for a minute, get moving around because we've been sitting still for a while and it's easy to get a little lethargic. Just wanted to encourage you to move. So put in the chat for me, which of these models, if you're operating in an integrated care setting, which of these models do you think you're using right now or you're striving to operate from? And if you don't know or you're not doing it, just say don't know or we're not doing any of this. That's okay too. We don't let people ever just listen in our trainings. You have to interact with the chat. That's Shirley. Oh, you're doing both. There is a formal hybrid model. So that's really exciting that you're doing both. Anybody else? I think someone said earlier that they are operating in the collaborative care model. Collaborative care, Francis, that may have been you that said that earlier. So like Mariah said, this is just going to be a few slides. It's a very brief overview of the 2 basic models. Next week, we have a more in-depth training about the primary care behavioral health model. And then the following week about collaborative care. Oh, go ahead. I tried to click it to advance the slides. Like, click, it's not doing anything. So take a moment and look at this slide. This slide includes all the components that's necessary for the PCBH model. It happens in primary care. It includes brief interventions. It includes a primary care provider and a licensed behavioral health provider. So it can be one or a combination of an LPC, LMFT, LCSW, or a psychologist. Those individuals need to be available and on demand for a warm handoffs. That means if I'm a physician, I'm in the exam room with a patient, and I'm able to say to the patient, I have someone on staff that would love to come and talk to you about blank. And can I introduce you to them? That physician leaves, and then a behavioral health provider comes in immediately afterwards. The intervention that behavioral health provider does in the exam room needs to be between 16 and 30 minutes, a brief intervention. Anybody on the call, you can just raise your hand if I can see you actually, or put your raised hand. Anybody a physician or a primary care provider on this call? Okay. Well, yes, Zane. When someone comes and operates next to you in one of the exam rooms where you're supposed to be seeing patients, and they take up a traditional amount of time as a behavioral health provider in an exam room, willing to bet you're going to get a little frustrated because physicians work fast. And when we have behavioral health providers as a part of the team in the primary care team, these behavioral health providers need to do brief and limited interventions. They need to operate as a generalist, just as a primary care operates as a generalist. A primary care provider can intervene in diabetes, hypertension, ear infection, sinus infection, various things like that, right? A behavioral health provider needs to also be a generalist in that way, where they can intervene with diabetes, hypertension, depression, suicidality, or obesity or sleep disorders and pain. So our behavioral health provider needs to know a wide variety of interventions for a wide variety of populations. Imagine that desk that's in the middle of all the exam rooms. You have your physician that usually stands there walking back and forth from exam room to exam room. Your medical assistants are there walking back and forth, and your behavioral health provider is there walking back and forth, intervening just before the physician comes in because you've had team huddles and you've been able to identify who might need an intervention, or immediately afterwards because something comes up during the primary care visit. That is an overview of the PCBH model. Do we have any questions, comments, or concerns about that? Okay. So our other model is the collaborative care model, and we've got a couple of people that are here on the call with us, and they say they're working in a collaborative care model. The collaborative care model, unlike the PCBH model, so PCBH is generalist. A behavioral health provider can intervene with physical health conditions and with mental health conditions. The collaborative care model specifically targets people with mental health conditions in the primary care office. The main prescriber, the person that oversees all of the patient care, even the psychiatric care within the collaborative care model, is the medical provider. The medical provider is responsible for the diagnosis. Ultimately, they're responsible for the treatment plan and the prescribing. Just because you have a psychiatric consultant does not mean that that's the leading physician on this. The leading physician is the medical provider, the PCP. You need to have, and this is they say the glue that holds everybody together, the mental health care or behavioral health care manager. The behavioral health care manager is the person that will meet with any of the members of the team, including the patient, the medical provider, and the psychiatrist. The behavioral health care manager has a registry of patients. So oftentimes in the collaborative care management model, you have a registry of patients with a specific diagnosis, and you're targeting improvements on that diagnosis. Example, depression, right? Example, diabetes. They have a whole registry of patients that have this specific diagnosis. You have evidence-based measures showing how they're doing based off of their diagnosis. You might use a PHQ-9 or a GAD-7 or a suicidality measurement screener. And that behavioral health care manager meets on a regular basis with a psychiatrist to review the registry and identify where patients might be dropping off and having some challenges within their diagnosis, or where patients really aren't improving when things should be improving at that point. So the psychiatrist behavioral health care professional. Francis, I love that. Thank you. That's very good. This is of course, the terminology by the Ames Center. And as we all grow and develop, we learn better ways of saying things. So I appreciate your feedback, Francis. Behavioral health care manager will take the recommendations from the psychiatric consultant to the medical provider. And then the medical provider, based off of that feedback from the psychiatrist, and the behavioral health care manager will meet with the patient and talk about adjustments to treatment based off of the feedback from the psychiatrist. So we're seeing that our medical provider, who are people that are seeing and taking care of patients with common mental health conditions in their offices every day already, they have limited support and limited resources. The collaborative care model provides the physician with the right kind of support and the right kind of resources, so they're not left hanging out there all alone, figuring out, one, do I refer this person out when there are really no options out there, right? Or do I manage them myself and do the best I can in this situation, which is usually pretty incredible, but they're always wanting a little bit more help. And so this model really provides them the right kind of help and support as they're identifying, diagnosing, and managing people with common mental health conditions that they're seeing in the office every day. It also includes regularly scheduled team meetings. If you want to go to the next slide, Sujina, that'd be great. So here we have our Venn diagram, right? And if you can remember a few slides back, there are key elements to integrated behavioral health, no matter the model. Those key elements are that they're team-based care. Yeah, COSAM is practical because psychiatrists are a rare breed. You are correct. And then, PCBH is practical because it's a ton of prevention, right? Let's help people stay healthy and well, do interventions in the primary care office, potentially even before a psychiatrist needs to be getting involved in any type of form. So going back to something we looked at a few slides ago, both of these models have the key elements. We talked about key elements, no matter the model. There's cost savings, it's team-based care. There is a behavioral health provider on staff, and it's evidence-based treatment, and they look at measurements to make sure their entire population is improving. Whereas the PCBH model, your behavioral health provider, is on staff and readily available to the PCP. They can really respond to any diagnosis, behavioral, mental health, substance use, physical health, and their interventions are brief, which means, again, 16 to 30 minutes in length. And it's short-term care. We're talking about 1 to 3 visits, right? Or 1 to 4 visits while the patient is in the primary care office seeing the physician. The collaborative care model is a little bit different. It's focused on a mental health diagnosis or a behavioral health diagnosis. There is a specific registry where we're looking at those and targeting those results from the evidence-based screening tools that we're using. And we have a psychiatrist. Unlike the PCBH model, the collaborative care model requires a psychiatrist to be a consultant to the primary care team. And they can have behavioral health one-on-one, right? Therapy and interventions as follow-up. And the collaborative care model traditionally, on average, can last 6 to 9 months, where it's a monthly intervention, monthly planning, monthly feedback, and monthly review of the registry to make sure that there are improvements. So although the collaborative care model can last much longer, for a patient, 12 to 18 months, depending on how they're improving, it's a longer term model than the PCBH model, which is traditionally based off of 1 to 4 visits with functional improvement for one identifying concern. Questions again? Any questions? All right, Sujina, it's all you. Ooh, ooh, ooh.
Okay, so sorry about the slides. Just gonna scroll through them really quickly. But I just wanted to share with you guys, I know we gave you a lot of information today about the models, but I know system change is difficult. Changing and transforming your practice can be very challenging. And while the significant barriers may exist in integrating your system, I wanted to share with you all these three organizations who have successfully integrated behavioral health and primary care. The commonalities among these organizations include prioritizing underserved vulnerable populations, increasing community collaboration, ensuring strong leadership early in the process, implementing a team-based approach, including the patient as an active participant, diversifying funding sources, and implementing data-driven best practices. This is, again, not an extensive list at all, but I wanted to share this with you to ignite some hope and encouragement, and to really show that these are proven evidence that this can be done. So let's do this, people.
I love that.
Okay, but before we close out, I wanted to give you guys an opportunity to, again, ask any questions, or based on the information that you've learned today, a question that is emerging for you is, go ahead and open up your chat and just fill in that sentence, complete that sentence for us. So no questions?
Francis, that's a fabulous question. And I love it, right? Because Mariah talked about how there's cost savings in it, but when we transform our system, how are we going to pay for that transformation? How are we going to pay for doing things a bit differently? And yes, there are ways to get paid for. There are approved CPT codes for this. And oh geez, Sujina, when is our fee for service training? So we have a training in a few weeks coming up on how to pay for integrated behavioral health in a fee for service environment. So I would encourage you to register and attend that one. We also do work in value-based care and value-based contracting, where we're working with our payers and practices to help pay for this in a different way than the standard delivery of payments for integrated behavioral health and for healthcare. So that's a long answer, and the short answer is yes.
Okay, let's move on. And the last is a bold idea I can recommend to my organization is, go ahead and fill in that sentence for me. This is the last one, I promise. Try to do something instead of have conferences and dialogues. We are with you.
Now, taking the first step to act. Francis, where do you work? You can unmute yourself if you want, Francis. No, that's enough. Love to hear where you work. We'd be happy to work with your team to make some first steps. If you want to get a hold of us, that would be amazing. Because it's oftentimes we listen and learn and listen and learn, and we go back to our everyday lives, and it's hard to apply what we've learned and actually make a movement and change.
Okay, so these are the upcoming trainings that we are going to host. In next 2 weeks, we are going to talk about the primary care behavioral health model and the collaborative care model. Both of those, Kara kind of touched upon them today. And then we're also going to host a fee for service training. This is where the CPT codes that Kara was talking about, those will be discussed in those training. So we have all these 3 trainings lined up for you. If you need registration link, please let me know. Feel free to email me. These are our contact info. Reach out to us. We'll be happy to send you the link if you want to be a part of these trainings. If y'all have any questions, please type in. If not, thank you all for joining. It was a pleasure seeing you all here today. We look forward to seeing you all again next week, and then a week after that, and then a week after that. Have a great day, people.
Thanks for being here.
Thank you, everyone.
Thank you.